All right, so I really appreciate SmartTrain for the privilege of giving this lecture. The pursuit of excellence will define you. I haven't reached this goal, but I keep pursuing it so that somehow I will embrace it after I've been embraced. Next slide. Yeah, cleft lip is an aesthetically unpleasant orificial deformity, and it affects the lip, the nose, and the alveolus. Hold on a moment. Hold on a moment. That's why it's really a pre-palatal cleft rather than cleft lip. It's the commonest major anomaly. Please continue. An unknown Chinese surgeon was the first to do it in 390 AD. There are several different ways of repairing, but the arrangement of the muscle components and their insertion is really important. Next. Now, there are various techniques to reconstitute the lip anatomy. Let's move on. Yes. Our most recent study published in 2017 suggests that the incidence is higher than previously reported about 40 years ago. And the Nigerian crane work showed that cleft lip, cleft lip and palate prevalence rate is 0.5 per thousand and almost equally divided between males and females. Next, please. And wherever you go, isolated cleft palate is the least frequent. In our own environment, cleft lip alone is slightly more than cleft lip and palate. Next one, please. In birth order, whichever one you look at, the first child is more likely to be affected with cleft, whether it's isolated cleft lip, next one, next, or isolated cleft lip and palate. Now, if you look at this, is a patient with isolated cleft lip, and on the right is cleft lip and palate. Both of them are bilateral. Next, and bilateral is where we are focusing on today. Next, please. In terms of so in isolated cleft lip, the bilateral is less common than right-sided. But when you have bilateral lip and palate, next, please. Next. Yes, but when you have lip and palate in association, you find out that the right-sided is less common than bilateral. So you find out that bilateral lip and palate with is more common than isolated bilateral lip. That's the point I wanted to show from here. That's also found in other clients. Next one. And male-female ratio is almost the same. Now, in terms of classification, it could be syndromic or non-syndromic. It could be isolated or in combination with the palate. And it could be complete, incomplete, or microform on either of the two sides. So you have combinations of complete, plus or minus a rotated premax, complete, incomplete, complete microform. Or you can have an incomplete that is on both sides, or incomplete with microform, or both of them are microform. These are the different variations you'll meet, and we'll try and touch how you handle each one of them. Next, please. Next, yes. So here you have, that was complete, one with rotated premax on the left, and then on the right, complete, the premax is not rotated. Next one. This is complete on the right side, incomplete on the left side. The next one, you have bilateral incomplete on both sides, but on the left, you can see that the baby has a rotated premax. Thank you very much. And on the right, you can see that that's not the case. So different variations will present themselves to you. Next. Now, in bilateral incomplete, the nasal symmetry is often preserved, but you can see that the prolabium on the one on the right is short and all the teeth show. So let's proceed to the next one, which is the microform. Now, on this side, you can see incomplete on the right and the microform on the left. And on this one, you can see both sides have microform. But the teeth is showing and the muscle is standing out at the edges. So next, this really requires repair. Yes, so you need to repair. Now, the patient must be appropriately weighted for age. We can't emphasize this enough. That is what tells you that the patient can withstand the surgery and will heal well and be free of anemia, pyrexia, respiratory tract infection. How about pre-surgical orthopedics? It's a bit controversial. Some surgeons love it because for the bilateral complete, it gives extra tissue and helps with the molding, but orthodontics are disturbed about the active device, particularly the latam, because of problems with maxillary growth. Well, we don't have a lot of it here, but we have to think about that now that we're doing more and more orthodontics. However, lip taping is useful, especially if it's done in the first 5 weeks of birth. That has a modest breaching of the cleft, the soft tissue, but it does nothing to bring the bone together. It's very important when you have seen that your patient is, can you go back a moment? You evaluate all the defects, complete on this side, incomplete on this side, very wide or narrow, so that you make sure you know exactly what you need to do preoperatively. If it's very, very wide, consider doing a stage repair, but then there are other things you could do to help. Do you do general anesthesia or local anesthesia? Local anesthesia is all right for adults and much older children, especially when you're dealing with lip alone and the microform parts. Next one. So remember, we've had lectures on anesthesia, but it's worth remembering that it's a shared airway. GA with endotracheal tube is the most reassuring thing to do, and the surgeons are most comfortable with that. There must be regular communication, and the plan is that as you are throwing in the last stitch, the patient should be getting awake. We'd love to have awake extubation so that all the reflexes are there. These surgeries, particularly for babies, are best done in the mornings. Thankfully, Smile Train has a rule that children that are less than 2 years old, their scheduling should not exceed 2. So we need to adhere to that strictly. So in terms of the repair, we do anesthesia. Remember to put in a throat pack. Lidocaine and adrenaline is used because we want the adrenaline. I encourage us to pre-mix the adrenaline lidocaine just before we do it. 1 hour before you infiltrate should be your maximum time so that you get the maximum effect. You can use local anesthesia for adults and then go on. Next. Yes, and then that will give you lidocaine and adrenaline. You infiltrate, whether you're using local and or you are doing general anesthesia, you still need to infiltrate. You do that till there's some blanching. Once there's blanching, that's enough. But you do that after you mark. If you infiltrate, it kind of distorts it and makes it difficult for you to mark. So you infiltrate after you mark. The 7-minute pause is so that you get the maximum vasoconstrictive action of the adrenaline. That pause is so important for you. You could use the Mulliken repair or the Manchester repair. These are the more common repairs that are done. And these are the instruments that you are likely to use. Your Gillis combined needle holder, scissors, Adson tissue forceps, your scissors. Size 15 and 11 blades are the most important thing. The calipers which you will use to measure, then swabs and artery forceps, as well as your needle with the gallipers. These are the minimum instruments you need to perform your lip repair. There are other things that could come, but these are the minimum. Next. Now it's challenging because you want to construct the nasolabial complex in 3 dimensions, incorporating the soft and the hard tissues, whilst you anticipate the 4-dimensional changes of growth and distortion. Some aspects, as the child grows up, will grow much faster than other. The tubercle area tends to grow much slower, while the lip itself grows faster. So these are some things you need to bear in mind as you want to get a good repair, particularly knowing that a minor nasolabial asymmetry will become much more obvious as the child grows up. And once you have made a primary repair, adjustments are not so easy. So it's challenging. Next. The principles are you want to restore the normal anatomy. Remember, there are 3 structures involved: the lip, the nose, the alveolus, and there are 3 basic structures in 3 basic tissues in each of these. For the lip, you have to deal with the skin, the muscle, the myelin. For the nose, you need to deal with the skin, the cartilage, the mucosa. And for the alveolus, you need to deal with the mucosa, the dentine, hello, yes, and the bone. All of them need to be addressed. Next. The goal is symmetry. Cartilages to construct the nasal tip and columella would deal with different options for that. You need to get a proper, and you need primary muscular continuity. That's so important. Size and shape. Next. You need to form the median tubercle and the central the long arms around the ala, and don't forget to repair the anterior alveolar cleft area under the nose so that food particles will not flow into the nose as the patient eats. You need to correct the nasal deformity by repositioning the alar cartilages. And remember, if there is a 2 mm difference in width or in the height between the cupid bow peaks, it will be noticeable to the naked eye. You must have the nasal tip, the columella, the cupid bow trough, and the tubercle all in one straight line so that the patient will look normal, as well as have a dimpled philtrum. So these are the things you must bear in mind. Bilateral straight line repairs have been done, but really they are not aesthetic. And I recommend to us the Mulliken repair, in which the lateral elements form the tubercle, the central mucosa, as well as the central myelin. And in this, the muscles are repaired in the midline so as to reconstitute the sling. Some bit of excess prolabium will occur. Classically, Mulliken would deepithelialize it so as to form the philtral ridges, but for some, you can excise them. Before, they were used as banked forked flaps, but I don't encourage us to do that. For the columella, okay, yeah, you excise excess prolabium. For the columella, there are different things that you could do. One is to do an open rhinoplasty using a V incision. That's the Cronin V2Y flap. It gives the best tip projection, and that's quite important in Caucasians, but it also introduces a scar. Nodorf described a technique where the prolabial skin is used to help lengthen the columella. He abandoned it because it was considered complicated. Then the fork flap technique is a staged one. It has largely been abandoned. I'm not going to describe that one, but I most frequently, currently, I use the tajima, where you introduce small stab incisions at the subtriangle region, mucosal edge, and through it, you quilt the cartilages. It brings on a deep projection. It does not introduce any scar that people will see. That's what I do most currently. But then sometimes you leave it well alone. We'll also see these different ones and we can take our decision. Now, the markings are of importance. The patient has to be supine position, draped, and you would have gotten ready. The filtral edge, the filtral flap from the columella is this. This is the filtral flap that you are going to use. You notice that from the edge of the columella is where you draw it. Our children come in different sizes. Thank you. Then the mucosal flap for undersurface of the is right next to it. So this is the mucosal. Yes, this one you will use to go down and turn into the defect. Then the filtral mucosal flap, that's this one. You are going to use that to turn down and help with the buccal sulcus. On the lip side, the good Lord has made it such that the color guides you. So all these things are color coded. So inside, that's the nasal mucosa flap. You will go along the difference in terms of the skin color and then go upwards so that you'll be able to lift that and bring it towards the septal flap, which is actually a continuation of your prolabial flap. Then you use the vermilion from the white and incorporating the white roll on both sides so that you will bring it to the midline. You need to incorporate the white roll on this side and on that side, and then make sure that as you are taking the prolabial flap to take it down, you don't leave the white roll behind. Otherwise, it's going to be a repair that doesn't look very good. Now, where will you put your neo-Cupid's bow pick? Your neo-Cupid's bow pick, like in a unilateral cleft lip, will be at the widest point. You can see that this goes wide and then begins to taper. It will be at that widest point. That's where you plan the neo-Cupid's bow pick. Now, all the symmetry is already inside the patient. So if you use this, you're going to have Cupid bow picks that are properly placed and sort of equal. And in this case, at the tip of the nose, you can see the V. That's where we will lift up and get the cartilages. Yes, once you lift that up, you see the cartilages around the soft triangle region, which you bring together. It will reduce the flaring of the nose and it will improve the tip projection. Next. So we will proceed now. I want to first of all start with this one that is bilateral. I did it sedation and local anesthesia. It's a big boy, as you can see. The mother used him for begging until a charity brought him to us in smartering. So note the flared ala, the wide deficient prolabium exposing teeth, and you can see that there is no nasal floor on either of the two. So let's go. Next one. I want us to realize that success in lip repair, bilateral or unilateral, is hinged on proper and adequate dissection. Once you have dissected very well, then you will be able to go ahead with closure. As you raise the flaps. In this one, this is where the prolabial flap goes, and in this one is hinged on the columellar vessels. You can see that we're going to use part of the prolabium on either side to lengthen the columella. And you won't see this until we turn the picture around. We take this and stop it short on the white row so that the white row goes with the mucosa. There has to be space for the muscle to come round. So on either side, you have used the markings that we had shown you to lift off the myelin, and then with your blade, you follow the color difference and get right into the nose, lift up all the flaps, and then separate the skin from the underlying muscle. I prefer to use the 11 blade in a sawing action to get the muscle out from the skin, the myelin, the mucosa, until it's like sausage. You need to have the muscle properly dissected all the way down towards the cheek so that you can mobilize it well. If you don't, you will not be able to create a muscle sling, or it might be under too much tension. And if it's under too much tension, a breakdown is quite likely. So you need to use your blade and carefully mobilize the muscle on both sides. You will need to lift up the mucosa from the maxilla on this side, because you will use that for the central lip elements. So if we go to the one on the right, we will, now this skin hook is where we move the prolabium down. You can already see from where the skin hook is that the columella is going to be augmented from there. It looks so natural. And the septal flap is a continuation of that. That is where we're going to take the skin from the nose to get to the floor. Here, you can see that the philtrum is landed on the columellar vessels. This is the philtrum, and you can see the soft tissue that is keeping the blood supply. And like I had said, the white row will move with the prolabial mucosal flap. Next one. Next, please. Yes. So from here, we will then be sure that the columella is lengthened. The prolabial mucosal turn down flap is inset, so you can see that the space where food would have tracked through the nose is closed. This has been turned down and meets with this on this side. This is also turned down and meets on that side, and you suture that. Starting from that part is a good idea. After that, the muscle that you have given room for, you bring it and you will suture both on the midline. Now, so as to get a natural look, when you have done that, you will bring a stitch from the edge of the alar base and the edge of the other alar base and hitch it to the base of the columella. That way you have the curve of the alar base done properly so that it doesn't square, it curves. And then the angle of the columella with the prolabium will be made and it will not be flat. That's an important thing to do. You will use you will then use the lateral elements to constitute the middle section. As you can see on the right, it's now been fully constituted. The tubercle comes because when you are cutting the excess, you bevel it so that there's a little bit more below than towards the cupid's bow. That beveling will create a little bit of a pout. So that will help get the tubercle to be reconstituted. So once you have done that, the repair is done. I used 4O Bilateral all the time in my repairs. Next one, next please, you can use nylon for the skin, or you can use subcuticular. If you use subcuticular, then you need to put steri strips. So that's how it looks in the post-op. Next. So in the ward, next please. Yes, you can see the face and the warm eye view, and then the before. Yes, this is the face and then the warm eye view. So you can see the symmetry of the nostrils, the alignment of the columella, the tubercle that has been formed. Here, you might be wondering whether we covered the teeth properly, but the next one, when he came, next please. Yes, when he came on the Smile Train Day, you can see that the teeth are covered. And that's him before, that's him after. Next, please, so that we can move on to the next repairs. Now, in the bilateral incomplete, the nose is usually symmetrical. So sometimes it's not necessary to touch the nose, sometimes. But the prolabium is often short and the incisors are exposed. As a result, just using the prolabial skin to form the philtrum will lead to some deficiency. You will need to get extra skin, so you will take it from the lateral lip element. When you are digging out the vermilion, you will take some extra skin. You would have measured to have an idea what measure of skin that you will need to take. So the deficiency of height becomes the extra width that you will take on both sides laterally. Next. So the markings are on the left. You can see that we have marked what we are going to excise, and we have, as you can see here, the Adson tissue forceps is taking hold of the white row, and you can see from the marking that we're going to take it to the prolabial mucosal flap. We're not going to use it for the philtrum at all. And then the lateral elements will form the middle section. So we're going to take some bit of extra skin here so as to augment. Now, on the right, you can see the incision. The incision goes all the way to the nostril seal. You need to be able to do that so that you can get the muscles properly aligned. And then the prolabial mucosa, you form it, you fold it over. It's going to help form the sulcus. Now, after this, you will get those together underneath the prolabium skin that is going to form the philtrum, and then close. Next one. Next, please. Thank you. So here, that's the same patient. We have closed the muscle. We have now brought the skin together. You trim off the excess vermilion, and on the right, you can see how we have brought the elements together and we're closing at the midline. Now, you should bevel so as to create a tubercle, and this helps to reconstitute the sulcus. If that doesn't happen, and I'll show you one patient where that didn't happen, you will still have the teeth showing even after the repair. Next. Next, please. Next, please. Yes. So you can see it's been done, and from the incision marks, you can see that the lip height is okay, but that is because we took some extra skin, and it came from this side and from that side. Again, in this patient, I use subcuticular stitches, so we use the steri strip. Aesthetically, it gives you no advantage, but it just saves you having to go back to remove stitches. So that's him before, that's him after. But you can see immediately that this is not a perfect repair because the tubercle is not there. The tubercle is not there. The lips closed, the teeth doesn't show, but there's one bit that we didn't get right, and that is the tubercle. We didn't get it in this particular one. Thank you. Next one. Next one. Now, I'll show you in this case what we did. This is bilateral. Both of them are complete. Note the short high-riding prolabium, and it's quite a problem. Next, please, because you need to do this with GA. Next. Now, this is quite challenging because next, you can see that there is a long distance that the lateral element, this lateral element naturally wants to come this way, but it will go around. It's not like that. It will have to go around, go back, yes. It has to go around this way, and the muscle has to be properly mobilized so that you can get it to close. Now, the muscle must be repaired in the midline, and you need to deal with these defects with a turn down flap. So these are the challenges with babies in this kind of a thing. Next. Next. In this particular instance, I left the columella alone. I did not use any of the lengthening procedures that had been described. And as you can see, it looks very tight. Initially, you get a bit disturbed, but I've noticed that they don't run into respiratory embarrassment. For my children, once they have recovered from anesthesia, I give them the normal diet, and I know that that's what the other people do as well. Next, but you can now see after about a year that the patient looks okay. We've been able to get the tubercle, the cubic bow, they're at the same level, the nerves are equal, and the columella isn't looking as bad as one might have thought. You've seen the face and then the warm eye view. So sometimes it's okay to leave the columella alone. Next. Next, please. Okay, but this is one in which I did a chronin V to Y. Both of them, this is also bilateral complete like the other one. In this one, I did a chronin V to Y, and you can see what it looks like. This was when the child came at birth. This was when the child had the repair. It's not the same month. The picture is not the same month. Those of the same patient. We're still able to get the tubercle, the cupids, both the nerves, and then we're able to get better teeth projection. This one was the chronin V to Y. Next, I'll now show you a patient that we had microform. In straight line repairs, I use that just for microform. That's when the adequacy of the prolabium can be ensured, and you can also see to it that the cupids, bow peak, and tubercle are acceptable, and that you can have muscle continuity. So once the principles are not compromised, then you can use a straight line repair. And its usefulness is mostly with microform types, and then other ones like a microform with an incomplete that is not so major. Next. Next. So this baby has a microform on the left and an incomplete on the right. And you can see from the warm eye view, you really don't need to touch the nose in this case. Next. Yes, so we've done a straight line repair, and in doing the straight line repair, we've now got the alignments that we seek. And in this case, the patient is satisfactory. Now, using the color, you can see the red line aligns all the way from one side to the other. And then we have the tubercle. So once you are able to get all these alignments well, you're okay. It's not the technique that is so important as the principles of getting the anatomy together that is all important. So once you are able for a particular patient to use one technique to get all the principles together, that's fine. Next one, please. So this patient had a longer follow-up. I just want to show you. He came with bilateral incomplete, and there's a rotation. Sometimes we wonder what to do about this rotation. Next. Next, please. In his case, I didn't touch the nose. I felt it was adequate. I did a Mulliken repair, but you can see it looks quite tight, and it doesn't look as though the lips are adequate. But remember what we said, that the lips and the mylon, that they grow much faster as the child grows up. By the time the child is 5 years, a lot of the lip growth has taken place. Next. So that's him at 3 years. And by the right, that's him when he came for alveolar bone grafting. He had alveolar bone grafting at the age of 6 years. You can see that the rotation has been taken care of. Once you're able to get the muscles together at the midline, that muscle action does its own work of molding slowly, gently over time. Next, please. And that's him at his 11th birthday last month. The father sent me his pictures. Next one. And you can see him as a baby, and you can see him at 11 years. It's not so easy to know that he had cleft lip at all. And this is the dentition. The bone graft was good. The teeth were able to erupt in it. You can see the teeth are complete, but he still needs orthodontic care. He still needs orthodontic care because you can see that the incisors still need to be worked on. But that's where the orthodontist comes in. We really need them so that we can have a complete smile. Next, please. That's him. Next. Now, this is why I said I don't like the Manchester. This girl had a Manchester repair. It's more of a straight line. You can see that in the center, the lip is still slightly open, and the look is somewhat unnatural. So we did a redo with Mulliken, and this is the same girl. So if you do a Mulliken repair and then you take care of the nose, you are going to get a much more satisfying and acceptable result. We're about finishing. Next one. Next one. Sometimes you may need to do touch-ups even when you think you've done something good. So that repair looked good, and here we made sure we had a tubercle, but I think we overdid it. Next, because next one, as she grew, she looked normal. We had the filtral dimple, we had the cupid bow peak, it looked right. We had the projection, we had the tubercle, but next, the mother complained, yes, that when she opens the mouth, there is this excess tissue, and that came from the prolabial mucosa. Well, that doesn't pose too much of a problem. You can trim it down and get it off as we did on the other side, and the mother was happy. So these are my thoughts on bilateral cleft lip repair, and I would love to take your questions and share with you my own experience, knowing that I'm not the ultimate. Thank you very much.
Thank you so much, Dr. Onah. Excellent presentation, and I agree. I'm sure every other person will agree with me. We have quite a number of questions, and I'll just take a few of them. So starting with the first one, children for age isn't adequate, but however have an adequate weight for height, meaning they are not malnourished. However, they may be stunted. Is it appropriate for them to undergo surgery since it will be difficult to achieve the weight for age required for the surgery? Dr. Onah?
I strongly encourage us to get the proper weight for age. I haven't shown you the ones that I had breakdowns in. I confess that I have had some breakdowns, but they have been much, much, much more common in the children that I did that were not appropriately weighted for age. I strongly encourage us to wait for the proper weight for age. Thankfully, Smart Train supports nutritional program, and just encourage them to keep feeding, get your dietitian to help them. Please let the patient be appropriately weighted for age. You will enjoy the experience a whole lot more. Your incidence of breakdown and dehiscence will be a lot less.
Okay. Then we have quite a number of questions from one of the attendees.
Yeah.
Some of them are a bit long, so I think I'll just break them in, take them one at a time. So the first one said, you talked of forked flap being abandoned. Is that your recommendation? What
Yes,
of those surgeons?
It's my recommendation because we can get acceptable columellar length in a single stage. In the forked flap, you end up using skin from the prolabium, and for men, that might end up resulting in hair growing on the nose when they are older, and that's embarrassing because you are not too sure that you're not taking skin from where you're going to have a mustache. So I don't encourage us to use that. There's actually been a revolution where the surgeons have insisted that the columella is in the nose, and I align with that. You can have single stage acceptable columellar lengthening. You don't need to go for forked flap procedures.
Okay. Then there's another question from the same attendee that says, can this technique be applied to people of Fulani descent with a pointed nose? He means the nod-off modification of Millard forked flap repair. He says this technique shows wide nose.
I think it is wise to do it with magnification. If you are doing it with babies, you can see that I showed it with an older child. The reason is that the central bit, the blood supply, is a bit precarious. Again, I confess I have once had a necrosis of that central bit, and nobody wants your flap to necrose. So yes, if the tissues are big enough and you can see well enough, but if you are not comfortable, a Cronin V2Y is good. The scar fades with time, but my best is actually the Tajima. The Tajima has given me acceptable results, and I recommend that as best. The beauty of plastic surgery and reconstructive surgery is options. So it is an option, but I think we'll be safest with the Tajima.
Okay, thank you for that. Then one more question from the same attendee. He commends your technique, but he wants to know if there's a way the Cupid's bow could be improved upon, because he thinks sometimes it's too wide and the scars are too obvious.
Yes. Yes. There's always room for improvement. Yes. I appreciate that. And the search and the pursuit of excellence is what defines a surgeon. So I think part of what I would do is to try narrowing the filtral flap next time. And I think if you use skin sutures, the scar is not going to be as wide, because when you do subcuticular, they don't always keep to it. And for bilateral, there's a lot of tension. And once you have tension, the scar is going to be wide.
Okay. Then another presenter has this question about so many techniques, and what would your comments be? I guess he's asking for, do you have a particular recommendation since there's so many options?
Yes, I apologize that it wasn't clear. I said that my favorite technique is the Tajima, the Mulliken procedure with the Tajima incision for lengthening of the columella is what I recommend as the one that has given me the best results. I just wanted to illustrate the different things that have been published in literature and what I have seen with some of them. Some of them can give you good results, but my recommendation is looking with Tajima.
Actually, I think you did mention it, but I think his question came in a little earlier than before you emphasized it, because I heard it like twice or thrice. So thank you for that. And then there's another question that says that, is it possible to see post-op pictures of the patient 6 months, 1 year, and 2 years post-op?
Sorry, could you say that again?
Somebody wants to see if you have post-op pictures at 6 months, 1 year, and 2 years.
I gave post-op for 3 years, 6 years, and 11 years. I think that's the one that you need more. But I could look for and send. I actually thought the longer term follow-ups are the ones that people want. But I do have 6 months follow-up. I think what we really need are the ones when the scars have settled down and the final shape has been taken. I think that's what we really need. But I can get that. It's not a problem.
Actually, I think the questions came in before you started. That particular question came in before you started to project the pictures, the more recent pictures. So I think that's about all for the questions now. What's left for me now is to say a very big thank you to our presenter, Dr. Onah, and to everybody for attending. We implore you to please sign in again tomorrow. We have another session, and the session runs all the way into July. And also the Smile Train team will make an attempt to make sure that the recording is available to everybody who's registered and attended the conference. So once again, thank you very much, Dr. Onah. Thank you to everybody, Smile Train, West African College of Surgeons, and to everybody who's attended. See you tomorrow.
Thank you very much. I apologize for listening. Thank you.